Hello, hi everyone. The topic of this lecture is overdentures. So basically, we'll be covering tooth-supported overdentures in this, since two overdentures are a type of complete denture removal processes. Okay, so learning outcomes at the end of this lecture, you should be able to define and classify different types of overdentures, identify the need, and select cases for overdenture. That is indications for overdenture, make appropriate abutment selection for the overdentures, and how to construct overdentures, how to take impressions. So basically, a denture which derives support from one or more abutment tooth by completely enveloping them beneath the fitting surface is called as an overdenture or a tooth supported overdenture. The abutment teeth are either endodontically treated or implant supported overdenture in case of overdenture that are supported by implant and locator attachments. So we can see here different types of overdenture. These are overdentures that are tooth supported, and this on the left hand side we have a coping, metal coping supported overdenture for the mandibular arch. On the right picture we have a bar type of overdenture. Now we have different bar designs in overdenture which will be covering later: header bar, dolder bar. Okay. So coming to the objectives of overdenture. So the objective is to distribute the stress concentration between the abutment teeth and the denture supporting tissue. So partly tooth supported overdentures are supported by the teeth as well as by the tissues, that is distal extension tissues. Okay, to balance the relationship between the need for the maximum support and for the aesthetics. Okay, so what are the advantages of having an overdenture as opposed to a conventional complete denture? One is the preservation of the alveolar bone. Since we have abutment teeth that support a tooth supported overdenture, so when we have teeth, the surrounding alveolar bone and the alveolar socket is preserved. There is the proprioception is maintained from the periodontal ligament. The They greatly enhance the stability of the denture when compared to a complete denture, and they provide positive retention by means of different bars or attachments such as ball attachment, locator attachment, equator attachment, different type of bars like Toda bar, Hilder bar, okay, zest anchor. These are different type of attachments that provides retention. The vertical dimension of occlusion is maintained because the teeth are present. Central relation is easily recorded because of the presence of a few abutment teeth. The tooth supported overdenture provide better lip and face support. The cuspid protection is there, that is the canines are present. Psychological benefit is there because the patient has a few of his teeth present in his mouth, so it is reassuring for the patient that it is not a completely removable type of processes but a partly removable and fixed type of processes. So there is improved mastication because of the greater retention stability. Post extraction comfort is better. Okay, and the overdentures provide positive support and comfort to the patient. Okay, so what are the disadvantages? The oral hygiene maintenance is pretty difficult for the patient, especially for the very elderly or malnourished patients who have poor neuromuscular control. This can result in periodontal problems, furcation involvement, pockets, and root caries. Okay, so all these issues will be there, which can result in failure of the tooth supported overdenture. Then, as I mentioned, uh, the same all these things age related issues, plus overdentures are highly technique sensitive. There is a great learning curve involved, plus the increased cost due to the restoration of the abutment teeth with different metal copings or precision attachments, or different type of bar or locator attachments. So then the increased cost for this attachment, increased lab bill, plus expertise required for making. Okay, so what are the indications when the patient has four or less retained teeth in an arch? The more the number of teeth, the more complex treatment becomes, the more chances of failure, the more difficulty in fabricating an overdenture. Okay, so minimum, ideally four or less teeth are enough for an overdenture and to make our life easier. Okay, so it is as a practical measure in preventive dentistry. So to prevent the extraction of healthy abutment teeth, we can convert the patient to an tooth supported overdenture instead of a conventional complete denture. It is beneficial for patients especially with congenital defects such as cleft lip, cleft palate, or hemimaxillectomy, hemimandibulectomy, that sort of patients. Okay, those facing the loss of teeth in one arch while the other arch is dentulous. So for such patient it is beneficial, say the maxillary arch is going to be predominantly edentulous or partly edentulous, and the mandibular arch has a full complement of teeth. So instead of giving a single complete denture in the maxillary arch, we can give a tooth supported overdenture in the maxillary arch, which will improve the patient's mastication and the chewing efficiency. Okay. And also in patients who have lost majority of the component of their teeth at a very young age, so in that there's a psychological benefit for the patient. When the retention is compromised, when we know that the ridges are very poor, there has been extensive residual ridge resorption in the distal extension areas. In such cases, if we think a tooth supported overdenture would be beneficial by taking support from, say, the cuspids or the premolars, then we can go ahead. Okay, and also in patients with xerostomia, because there is no retention, there is no atmospheric pressure, there is no cohesion, there is no adhesion, okay, and there is no capillary action. So in such cases, if two or three or four teeth are present, it's better to use them for overdenture if they are healthy. Okay. Contraindications: patients who lack the motivation or who may not maintain the oral hygiene properly, in such patient is contraindicated. Patient with systemic complications, patient with inadequate interact space, so in such cases we will not have sufficient space for the attachment or the bar, and on top of that the denture. Okay, patients with grade 3 mobility of the abutment teeth, definite contraindication. In teeth that have had extensive periodontal breakdown resulting in recession and a large crown to root ratio, so a short root will not provide much retention, and the overdenture will fail within a couple of years. Okay, so and patients with extensive ridge resorption, in such cases also where the severe alveolar ridge resorption is there, so in such cases also then the denture will become mainly tissue supported, and all the load will be present on the abutment teeth, and this can be disastrous later on. Okay, so any situation where we do not think is going to last for a long time are contraindicated. Okay, so this is contraindications continued, and patients with where endodontic treatment cannot be performed, say there is perforation in the tooth, there is furcation involvement, there is calcification of the canals. Okay, so or internal resorption or external resorption, in such cases where endodontic treatment cannot be performed, obviously the tooth is becomes a non indicated tooth for an overdenture abutment. Okay, so coming to patient selection, when the FED-CPD cannot be fabricated for a patient, in such cases there are we have two or three, say, healthy abutment teeth with good prognosis, we can convert the patient to an overdenture. Regard Regardless to say, the abutment tooth should be sound periodontally and endodontically. They should have sufficient width of adult gingiva, minimum at least 6 to 7 mm of alveolar bone should be present around the root. Frontal status should be there should not be no vertical bone loss, because vertical bone loss means poor prognosis. There should be minimum crown to root ratio. Okay, and there should be minimum mobility, say grade 1 or up to max grade 2 mobility to a certain extent we can consider. There should be no pockets. Okay, next, patients who maintain good oral hygiene, patient who have good dexterity, good neuromuscular control, patient who have low caries index, patient uh, have, as I mentioned earlier, with good attached gingiva, especially canines and the premolars are the most favorable teeth for abutment, and in incise central incisors and molars such as second molars and first molars are actually not a good choice for overdenture abutment. Okay, and that is not the case, we can consider the patient for an implant supported overdenture, especially in the mandibular arch where the cost is also involved. Okay, and patients with cleft palate, in such cases we should try to save at least two or three abutment teeth. Okay, so conventional overdentures are retaining teeth permit the stress of the occlusion to be borne partially by the teeth and by the tissues. Okay, so that is the so mainly overdenture get the retention from the teeth, but the stability and support from the tissues. Okay, so different type of overdenture attachments are non-coping abutments, non-coping abutment endodontic therapy, that is there is no metal coping fabricated, just the teeth are endodontically treated and used as a overdenture abutment, over which the overdenture is fabricated. But in this, there is a greater risk of secondary caries, the greater risk of fracture of the abutment teeth. Especially coping abutments are indicated where a metal coping is cemented onto the abutment tooth after preparing the tooth, and then overdentures fabricated over them. And lastly, we have the more specialized form, that is the abutment teeth with some form of attachment. Okay, so these are coping abutments. These are abutments with precision attachments. You can see over here there are two teeth that have a coping attachment, which have two ball attachments on either side of the coping. Okay, so non-coping, the procedure is fairly easy. There should be for any kind of overdenture there should be sufficient inter-arch space. The advantage here is it is economical. Minimum preparation is required. The vitality of the teeth can be maintained. Okay, whereas sometimes when the teeth has severe attrition or exposure of the dentine, or it is too close to the pulp due to teeth surface loss, it is advisable to do endodontic treatment and then fabricate a overdenture. Okay, coping abutment, it is always better to fabricate a metal coping or a cast coping on the abutment teeth, especially when you are going to do root canal treatment for the teeth to improve the longevity of the abutment teeth, to improve the life. If any time you do, you should have good periodontal support, good oral hygiene, no inflammation. You should not, and always you should have sufficient crown to root ratio of at least 1 to 1 or 1:2 ideally. Okay, so copings are different types. Short copings, usually are just 2 to 3 dome shaped coping, which do not give any retention, just they are kept in place. Then we have long coping of 5 to 8 okay, which can be used for telescopic coping abutment with endodontic therapy. Okay, so most of the time it is preferable to always do endodontic treatment and then fabricate metal coping to reduce the chances of sensitivity, pain later on, or any periapical infection. Okay, which can result in loss of the abutment and loss of the overdose. So these are some of the various type of attachments that we have: stud attachments, Dalbo attachment, Seek attachment, Just Anchor, Ottoman. Okay, so you can go ahead and see these. So these are some example of these are ball shape attachment. This is what you call a Zest Anchor. These are again ball shape precision attachments. Okay, these are all castable copings which can be waxed up to the wax pattern on the abutment teeth, and then they are cast in the metal of choice, usually nickel chromium, copper chromium. This is an overdenture bar which can be used either separately or with different type of attachments, such as a ball attachment, equator attachment, or a mini ball, or the regular ball attachment. These are prefabricated. We can also have them as a plastic copings which can be used to, you know. So let us move on to the slide. So here this is another example of ball attachment. This is the coping which will be retained inside a metal housing inside the denture. Okay, so next, this is the again example of waxed up ball attachments on the cast, which will be then cast in the form of this metal copings in the picture on the right upper hand side, and then these copings and then the attachments of over these ball heads will be incorporated inside the dentures inside a metal sleeve. So these are called as housings, and inside these housings we have these silicone sleeves, retentive sleeves. So this is another example of a precision attachment with locator attachment on either side. This is can be designed nowadays with any CAD CAM software like exocad, and then it is milled out of titanium or chrome cobalt, and then the ball heads or the ball attachments can be manually screwed into this. Okay, so these provide very good retention, and but these are expensive. This is another example of attachments for a tooth supported overdenture. So here is a post. So this is a equator pivot. So the pivot or the post goes inside the endodontically treated tooth, and what you call, let me get the laser pointer. So this post or pivot goes inside the endodontic post space prepared inside the teeth. This is the equator attachment which is jutting out of the coronal portion of the root, and this is the metal housing, and this is the silicone retentive sleeve which will be incorporated inside, picked up inside the denture. Okay, so we have different colored sleeve for different amount of retention. Okay, so this is again we are showing the same thing over here. These are again ball attachments on endodontically treated teeth. Okay, so this is all laboratory technique which you can do later on. This is a bar attachment with a equator attachment on top of the bar for added retention, and this is equator attachment which is attached on top of the bar. You can see, note the screw or the threads under the equator attachment which can be screwed into a milled bar. Okay, again here we have a metal housing and a silicone retentive sleeve. The metal housing has a stud on top which can be picked up inside the denture, or which is retained inside the acrylic of the denture. These are various tools, drivers for fixing the, you know, equator attachment on top of a milled bar. These provide very good, excellent retention. Okay, and the good thing about this equator bar or the locator bar house attachment is that even if the teeth have a tilt of 25 degree to each other, even then they can be incorporated on top of the tooth. Okay, so they compensate for up to 25 to 30 degree divergence of individual teeth. So combined divergence of up to 50 degree between two opposing uh, overdenture abutments can be compensated with the use of equator. Locator are also similar. Now coming to the selection of the abutment tooth for the construction of a tooth separate overdenture. So first of all, you should evaluate the periodontal status of the teeth, evaluate the pocket, any inflammation. Okay, you should evaluate any crown root ratio, whether it is ideal or not. You should evaluate for the mobility. You should evaluate whether, if pockets are there, whether you need pocket elimination surgery or flap surgeries. Then the abutment teeth need to be prepared in a tapered shape. Okay, and typically when we are preparing metal copings or coping type of abutment, we have to prepare a chamfer margin all around the abutment teeth to receive the cast coping. Okay, and it is very important to take care that the oral hygiene status is good. Okay, otherwise chances of secondary caries and inflammation of the marginal gingiva are very high. Optimally, we should have at least two opposing canines or two premolars in each arch. Okay, a single abutment sometime can be used, but usually not indicated. Approximately adjacent abutment teeth makes the abutment, cleaning the abutment teeth very difficult. So always it is better to have one abutment on either side of the arch instead of having two adjacent abutment like canine and one premolar on one side of the arch. Okay, and it is always better to have periodontal treatment done for the abutment teeth prior to fabrication of the coping and prior to fabrication of the tooth support overdenture itself. Okay, always overdentures should have a metal base inside them to prevent the fracture of the repeated fracture of the overdenture. Metal base provide an accurate base upon which the correlations can be made, provide a precise adaptation of the abutment coping to the metal denture base. Okay, so this is again laboratory procedures about how a equator castable attachment overdenture is fabricated. You can see over here in the pictures. You can go over the pictures. The head legends are given under the picture for clarity, for understanding. This is how a metal framework wax pattern is fabricated for the overdenture or the tooth support overdenture. You can see this is the green color is the relief wax to provide space underneath the metal framework for the acrylic, and the yellow and red color is the metal framework for the tooth supported overdenture. This is sprued, then this is the cast framework. The cast framework is then picked up in or relined inside the overdenture over here. Okay, this is how the locator or equator housing are picked up inside the denture. First holes are made inside the denture approximately over the position of the equator or locator attachments. Then the housing with the silicone sleeve is placed on the abutment teeth, Then the denture is filled with self-cure polymethyl methacrylate resin, and then it is pressed into place and the patient is asked to bite, and then once the material is set it is removed and the excess flash is trimmed. So this way the housing and the retentive sleeve is picked up inside the denture. Okay. And so ideally we keep a piece of a rubber dam or a spacer, processing spacer, which is provided by the manufacturer of the attachment to prevent the acrylic going underneath the attachment and getting locked inside. So this is again the same procedure that was prescribed before. Okay, and thank you all for a patient listening.